Stop the Bleed teaches one rule. The Department of Defense teaches the opposite. Both are real tactical combat casualty care doctrine. By the end of this video, you'll know which rule applies to the situation you're actually in and the 4 mistakes that get civilians killed in tourniquet emergencies. Stay with me. The man teaching you is Patch, 21 years in Special Forces. 18 Delta, that's the Special Forces medic. He's used a tourniquet on a teammate. He's taught a Kurdish Peshmerga sergeant to put one on his own leg with one hand. Watch this. Patch teaching the rule that overrides everything you learned in your civilian Stop the Bleed class.
One of the questions I get often with Stop the Bleed, tourniquets, old school of thought, and if you're still being taught this, stop it. But when it comes to having to place a tourniquet for a large extremity bleed, go high, go fast, always. Go as high on the leg as you can, as fast as you can. Go as high on the arm as you can, as fast as you can. The old rule of thought was go 2 to 4 inches above the wound and apply the tourniquet, unless there's a joint there, in which case you go above the joint 2 to 4 inches. Couple of reasons that's wrong. Number one, if there's an artery that has been compromised, it's going to retract. It's a muscle, okay? It's a smooth muscle, and they retract. So when they retract, if the wound is here and I put the tourniquet here, but the artery retracted, well, I'm basically clamping on nothing. I need to get the wound way above that artery's ability to retract. And number two, on distal extremities, I'll use my forearm. I have a radius and an ulnar bone. Just like with my legs, I have a tibia and fibula. And where do you think my main artery, vein, and nerve complex runs? It runs in between them. So if I get something here and I try to put a tourniquet on it, I'm just trying to squeeze these 2 bones together in order to get them to stop the bleed, when in fact, those bones will not allow me with the tourniquet to stop that bleeding. I will have to put copious amounts of packing material inside that. So that's
what you just heard was Patch teaching the published Care Under Fire doctrine. Section 2.1 of the official Tactical Combat Casualty Care Guidelines, maintained by the Committee on Tactical Combat Casualty Care. The phrase, high and tight, as proximal as possible, is verbatim from those guidelines. Proximal, that means closer to the heart. The 2 reasons matter. Reason 1, when an artery is severed, it does not stay where the wound is. The artery is a smooth muscle. It retracts upward toward the heart. If you place your tourniquet 2 inches above the visible wound, you may have placed it below where the bleed actually starts. Reason 2, forearms and lower legs have 2 bones running parallel. The artery runs between them. A tourniquet there cannot occlude an artery sandwiched between bone. Now look at this. Most civilians don't know there are different types of tourniquets, and one of them might fit in your pocket.
So you got the standard cat and soft T tourniquets, a lot of pouches and stuff for them, but then you got these guys here. I really like these guys because they also work on working dogs, and they work on children and small statured people as well. So it fits in my pocket, smaller than a pocket knife, and I don't look like a Boy Scout going to camp with my everyday carry. So that's something that I carry. I keep that on me. Your belt will not work. Don't let anybody tell you otherwise. All right.
The TCCC approved devices Patch just showed you. The CAT, the SFAUC TTW, and the smaller variant for working dogs and small stature patients all generate enough pressure to occlude an artery. An improvised tourniquet from a belt or a piece of cord almost never does. He just told you. Don't let anybody tell you otherwise. Now watch how Patch actually applies one in the field. Listen for the line that should be on every wall of every training facility in the country.
One of the questions that I get is, can I just bring it up the leg? Yes. One of the things that is not being employed right here is clothing, and the simple reason for that is I keep cutting up and ruining our clothing. So if there's clothing there, I'm gonna completely expose everything. That way I can bring the tourniquet up from the rear. If that's gonna save me time, and that's how I practice, that's how I want you to do it. Don't say you're gonna do it one way. Don't armchair quarterback yourself. If you're not actually here, you're not actually doing it, then you're not going to do it the way you practiced, okay? We never rise to the level of the occasion or the level of the emergency we're faced with. We always fall to the level of our training. So now you know exactly what I will do if I have a gunshot wound to an extremity, upper or lower, in a open setting environment.
We never rise to the level of the occasion. We always fall to the level of our training. That's the line. Patch just showed you the application sequence. Expose the wound. Bring the tourniquet up the limb from the rear. High and tight. Practiced under field conditions. Documented in TCCC Section 2.2, Tactical Field Care for the Post-Threat Reassessment Phase. Now here's where most civilians fail in real emergencies. The 4 mistakes Patch sees in every class he teaches. Mistake 1. People are afraid to crank the windlass tight enough. The windlass, that's the rod you twist to tighten the strap. The tourniquet works because it is painful. If your conscious patient is not screaming, you have not tightened it enough. Mistake 2. People place the tourniquet directly over the wound. The tourniquet has to be above the wound, between the wound and the heart. Direct pressure goes on the wound. Tourniquets occlude the upstream artery. Mistake 3. People loosen the tourniquet to check if the bleeding has stopped. The published doctrine on this is unambiguous. Once the tourniquet is on, it stays on until a higher level of care manages the conversion. Loosening it lets blood back into a destroyed vessel and pushes the clot loose. Mistake 4. Wrong device. Improvised tourniquets from belts or cord almost never generate enough pressure to occlude an artery. Buy a real TCCC approved device. The CAT, the SFAUC, the SAM-XT, $20 to $30. The conversion criteria are explicit in the published doctrine. 3 conditions, all required. The casualty is not in shock. The wound can be monitored continuously. The limb is not distally amputated. Time matters. Quote, every effort should be made to convert tourniquets in less than 2 hours. End quote. Upper limit. Quote, do not remove a tourniquet that has been in place more than 6 hours unless close monitoring and lab capability are available. For a civilian, if the ambulance is 15 minutes out, do not convert. Leave it on. Mark the time. Tell the paramedics when it went on. You are statistically more likely to encounter a major hemorrhage than to use a fire extinguisher in your lifetime. Carry a tourniquet. Carry a real one. Put one in your truck, your range bag. If you want to learn this, so it transfers to your hands when you're scared and shaking, Team SFAUC teaches tactical medicine for gunshot wounds. 3 days. Real kit. Real training equipment. Scenarios under stress. Class info is at tmsofast.com. One more thing. Tourniquets only work for limb hemorrhage. About 60% of preventable battlefield deaths are not limb hemorrhage. They're junctional bleeds. Wounds at the groin, the armpit, the neck. Places where a tourniquet won't sit. The next video shows you what to do when the wound is somewhere a tourniquet can't go. Subscribe so you don't miss it. Drop a comment with the brand of tourniquet you carry. Other viewers in the comments are checking each other's gear right now. The doctrine has a saying that maps perfectly to the civilian context. We go high. We go fast. If you remember nothing else from this video, remember those 2 sentences. Train hard. Carry one. Save someone.